in community pharmacy, we were scrapping around for pennies.
Yep.
And to get anything, it was just ridiculous, right? And and when I was in general practice, things happened much quicker.
Oh, really? What do you mean?
Hi, my name's Ankish Patel, and welcome to the Pharmacy Planet podcast.
Ankish, welcome to the Pharmacy Planet podcast. It's great having you. Ankish, I've known for a long time. We went to university together, right, Ankish?
We did.
The team were actually asking me, what does Ankish do? And I said, you know what? I actually don't know. I said, all I know is I went to university with him, and that was that. So, Ankish, do you want to just give us a brief rundown, what you're just quickly, what you're doing at the moment?
Right, okay. So I'm just at the end of a project for Welsh Government. So I got commissioned to do a review of general practice pharmacy. So pharmacists, pharmacy technicians working in general practice in Wales.
Okay.
So that's going to just be submitted really soon, and that's going to inform like future policy in Wales. So that's big.
Okay.
And I've started a job in Nottingham for an out of hours service. So I'm head of clinical transformation, the clinical lead for transformation, and outbreak hub, which is like to deal with any new outbreaks that come out there. And in my part-time hours where I've got them, I'm working in medicinal cannabis, and I do some digital clinical safety officer work for startups.
Okay, so that sounds quite jam-packed. Now, when I knew you at university, this is a completely different Ankish that I knew at university. So Ankish was he was the only person I know on the pharmacy course that had full dreadlocks, right? So he had you wouldn't believe it right now, but he had full dreadlocks, and he was probably one of the coolest looking guys you would probably get on the pharmacy course at the time. So Ankish, what has happened from that dreadlocked kid who was at university to now? Where do we start? So what did you do when you left university?
Wow. So first of all, I failed that first year with you, right? So
did you?
I think, yeah.
Did you flunk?
I flunked, and then I dropped. So I was were you on the bachelor's? Yeah?
Yeah.
So I was on the bachelor's, failed that first year, and then I dropped into the master's. So
there's too much partying, dude.
There's a lot of partying.
Yeah, there's too much partying.
Yeah, I think it was known as Kish in my block.
Yeah.
So I spent 5 years at uni instead of 3, which was really good fun.
Yeah.
Did my pre-reg in Manchester.
5 years instead of 3?
Yeah, because the 3 was the bachelor's.
Because you went to the 4-year course.
Yeah. And then my resit year, there was no coursework. So it was just lecture attendance. So it was 2 years of fun.
All right, okay.
Yeah. Left uni, straight into community pharmacy, because my old days as a newsagent. So I was quite happy in the community pharmacy. So went through the whole Boots, multiple bit, LPC, management, regional management, worked for Boots and Well Co-op. I remember my dad laughing at me. So my dad retired at 52 with a shop. Yeah. And when we got taken over by Best Way Cash and Carry, he was the first one on the phone. He was going, yeah. You went to school, did pharmacy, and now you're working for a cash and carry. I was like,
you even then, you didn't strike me as what you would have thought a pharmacist would be like. Why did you do pharmacy? You didn't come across as pharmacist to me. You didn't shout pharmacist.
So I wanted to be a journalist. So that was my...
now's your chance, dude.
Now's
the chance.
So when I was doing my visits for university, I had my A-levels going. So I was doing English Lit, physics, and chemistry, something like that.
All right, okay.
And then my dad found out I was doing English Lit, and that came to an end. So.
Oh, really?
Yeah. And I was only doing English Lit because I really fancied a girl I did it with in GCSE, and I sort of was following through. So it gives you my level of maturity at that age.
Yeah, well, I suppose there's a good reason as any, right?
And my uncle's a chemist, so he came over from Tanzania, got a job with ICI, and everyone who worked for ICI back in the 70s had to have a degree, so they funded him through UMIST in Manchester.
Okay.
And he was like remember NMR?
Never.
Nuclear magnetic resonance.
Oh, yeah.
So he was a specialist in that area.
Oh, right, okay.
And he jealously looked over in the 80s and 90s at pharmacists with big fat 7 Series Beamers and went, they make loads of money, you should do that.
Right, okay.
And that's how I ended up doing pharmacy.
Well, it's definitely not like that anymore, but okay. Okay, how do you think pharmacists, because you were in practice quite early, relatively, for our profession, right? For community pharmacy especially. How do you think community pharmacists were viewed when you first started entering practice?
So
Was everyone quite like welcoming, understanding that what you're bringing there? Or was it?
yeah, it's funny you should ask about that. So number one, I thought I was late to the party,
Yeah.
which is weird, isn't it?
Yeah,
I thought
yeah.
I was late, but I wasn't late.
Yeah.
I went for a couple of interviews, and I didn't get a right vibe, and I ended up in a practice where the GPs, there was just no ego.
Yeah.
I had a fabulous mentor called Jill Jones,
Yeah.
who just, first day, she just sat me down and went, "There's stuff you know that
Yeah.
I don't know, and there's stuff I know you don't know."
Yeah.
And it was an open door policy for everyone in that practice. So that was my perception of what it was like.
Yeah.
When I started working in a broader PCN space, and I realised that everywhere's not like that. It's quite harsh.
Okay, and what do you mean by harsh? Come on, then break it down, Ankit.
You know what? When we've first had people coming in, it's a difficult space when you don't know what people want you to do,
Yeah.
and people don't know what you can do.
Yeah.
It's a recipe for disaster, right? Because people are like, "What are you doing here?" We had pharmacists open in post,
Yeah.
sat in cupboards with no induction, no one to talk to, just going, "What's going on?" And we were viewed as a threat by some GPs. I think it's things have changed now, not massively in some places,
Yeah.
but community pharmacy has always been seen as a threat to general practice and their income, especially when things like flu happen and other stuff.
Yeah.
So suddenly when a pharmacist turns up into your practice, there was also a bit of fear around what are these guys doing, and you have to. What's not always understood is that, general practice is a business. It's
Yeah.
the same as community pharmacy, a subcontract of the NHS.
Yeah.
And when pharmacists came into that space, there was no one paid more than a GP,
Okay.
generally. So we were going in high,
All right. Okay. I find, my experiences with a lot of practice pharmacists. I mean, there's good and bad. Some are great, and
Yep.
some, especially the newbies that come into practice,
Yeah.
and they've just been given a task. Just change this person over, change these drugs
yeah.
over, or make these all 56-day prescription. When they've just been given a task, sometimes you'll speak to them and they're like, but, we've been told to do this and it saves money and I have to do this. And it's just such a lot.
Yeah.
Can you just please use a bit of common sense? There's a patient at the end of this.
Yeah.
We've got a clear issue here. But it's almost a case of, I'm here to fix the GP's issues and the surgery's issues.
Yeah.
And frankly, your issues are not my issues, and I'm going to just do what I want. And so we find that sometimes a practice pharmacist, since they've started, there's a practice pharmacist everywhere now.
Yeah, there is.
Some are, like I said, some are great and
Yeah.
understand where you're coming from and work well together.
Yeah.
Some are just like worker bees there to do a job, and it just frustrates the heck out of us and the population
Yeah.
who we're serving at the time.
Yeah,
So
I agree.
Oh, that's it. That was well. Thank you for that.
Yeah.
This is going to be a good podcast. We should just carry on the same, right?
I think when people come in, it's like we were lucky in not start. Well, not lucky, but we were all employed through a GP federation. So
Yeah.
a federation was owned by all of the practices,
Yeah.
and we employed everyone for them. So what that gave me was an opportunity to be able to bring people together.
Okay.
We had groups of 5 pharmacists, all from different PCNs, all learning from each other. We had senior pharmacists mentoring them, and we were able to sort of coach and teach and be able to build that type of understanding. Because I think I went into general practice with 15 years of experience and a lot of life experience as well,
Yeah.
even without COVID and sitting at home for a few years and all that scary stuff that happened. And I was able to take that into the space and be able to make change. And if you've got people that are prescribing and they don't understand patients,
Yeah.
don't understand patient journeys, they don't understand how the infrastructure works, and no one's there to teach them, then you make a little decision and the ripples create chaos.
Yeah.
And then before you know it, people don't want to work together. They don't trust each other. Why have you done that? Because that's done that to me.
Yeah.
And it's all about communication and relationships. So you can't have massive change like PCN without investing in the relationships and the trust around it,
Yeah.
so people can work together. And I think that's the key, really.
And some people have done that well. Some
Yep.
areas have done that well.
They have.
And some are, I would just say, like non-existent. I mean, even the surgeries within a PCN,
Yeah.
there can be a lot of like antagonism even there, right?
A lot of surgeries don't like each other.
Yeah.
So
So that's what I was trying to say nicely.
Yeah, you were. So, but equally, it's like saying to the 3 multiples,
Yeah.
4 independents, here you
Yeah.
go. Here's £1 million.
Yeah.
You spend it on the staff you want, and you decide how you share them.
Yeah.
And we're not even going to check. You just do what you want. It's going to kick off.
Yeah.
Am I getting my fair share? Are they doing something over there that I can't see over here? And I think what it comes down to is leadership. You know, when you say it happened there,
Yeah.
I was there. It's taken me a long time to understand that, and I say it humbly as well, but at least there was someone there
Yeah.
to be able to guide it, support it, that was able to try and be inclusive. And where we've had leadership and pharmacists, pharmacy technicians have been supported to be leaders within certain spaces, I think that evolution's been much better.
Okay. So like, you know, my experience, I've always been pretty much working for myself. You're a contractor.
Yeah.
You have the freedom to do what you want. You don't have to work. It's not a hierarchical space in any way, shape, or form. Yeah. Whenever I've had to deal with systems
Yeah.
or what were they before? They were ICSs, but CCGs.
Yeah.
CCGs. Whenever I've had to deal with it, to me, it's just unbelievably frustrating. A large amount of red tape.
Yeah.
Very little gets achieved quickly. It doesn't matter even if somebody knows the right path or what needs to be achieved. Sometimes they can't just do it. There's a process to get anything achieved. I can't stand that hierarchical space. So tell me, what is it like working in these? Because you've seen it from both sides, right?
I've seen it from
so
both
if somebody's so there are some people who've permanently always lived in that hierarchical space.
Yeah.
Am I even pronouncing it right? Is
think
it
so.
hierarchical?
Hierarchical.
Is it hierarchical?
Hierarchical?
I'm not sure. Right, we'll have to edit that out all of a sudden. But
That's
anyway,
fine. No, should we keep that in?
yeah, all right. Whatever. Anyway, the point is,
Yeah.
what is how did you manage that? And just tell me, what is it actually like?
So I'm pretty anti-establishment, or I have been in the past when I was younger. You know,
Dreadlocks.
that whole bit of you know the whole just fight the system type of mentality, and so I've found that difficult as well, right? So and I think the differences I saw within general practice and community pharmacy. In community pharmacy, we were scrapping around for pennies.
Yep.
And to get anything, it was just ridiculous, right? And and when I was in general practice, things happened much quicker.
Oh, really? What do you mean?
It would if
So what-
and I think maybe that's my experience of being around PCN. Suddenly there was funding in the space,
Yeah.
and I was able to put proposals together, and I was able to steer and guide and create a bit of financial headspace, and then be able to do what I needed. So I found it okay, but I think the conditions were that way because PCN was like no one really owned it. It was a sort of in the system, and no one was really monitoring it. I would say, you know, there was little bits of
It
it.
was a bit like a mini Quango, wasn't it?
Yeah, it was a little.
It was like.
I'm not sure about Quango,
Yeah,
but, it was, but
it's
there was
got funding, and no one's quite sure who's in charge.
exactly. But the funding was there, and that gave me a lot of freedom to be able to operate.
Yeah,
So
yeah.
I wasn't really.
So you went and bought yourself a new car, went
Yeah,
on holiday.
just
Do you know
got
what
a
I
big
mean? And that's where all
extension,
your funding went.
Got a big extension, all that sort of stuff. Yeah, so but you know what? It was quite liberating because I had the bosses that I had gave me a lot of autonomy. They trusted me. They judged me on outcomes. You know, not where are you this morning? Where are you? I had a lot of freedom to go and do what I needed to do and just keep them informed on what was happening. So, and that suits me to a T. You know, that's where I thrive. In those types of environments.
So you've probably seen, because you've seen so. Oh, hold on. Where did you move on to after this?
After PCN,
Yeah.
So after that, I was doing lots of business transformation for them.
Okay.
Brought in lots of money through pharma partnerships and stuff like that, you know, for projects and stuff. And then I ended up doing the Welsh Government role, and then in my role right now.
Okay.
Took 3 months off in between, actually.
All right. Okay. So now, working in this wide variety of healthcare, healthcare system. What are the pluses and negatives? Where do you think because healthcare? I think healthcare outcomes for our patients is in the UK. I think they're poor.
Really poor.
They are. So the outcomes are poor. So we know something needs changing, right?
Yeah.
I've got a community pharmacy view, obviously, because that's what I know. Yeah. But you've got probably a lot wider view and a lot better kind of overview of where things change. Where do you think things are going wrong for our patients and outcomes? What's going wrong in the system?
You know what? I think what encapsulates it for me is how people talk about patients sometimes, and and words mean things, right? You know, they're important.
Of course,
you know, and when that person you speak about is in the room, then it really means something. And sometimes we hear a lot of people say, "Oh, you know, they're hard to reach."
Yeah.
You know, hard to reach, and I think when you think about the terminology, hard to reach, I think that's part of our problem. Like the way I view that, and a lot of people, is underserved. You know, if that patient was sat here and we're going, you know, you're hard to reach, sorry, you know, that's why that puts the blame on that individual. We couldn't find you. You know, you're right in the city, in the most deprived area, but we couldn't find you. We couldn't find you. We couldn't find you because you couldn't read our signs.
Okay.
You know, like the NHS app is only in English. Sorry, oh yeah, that's not our problem. You know, so I think if we listen to our patients and our communities, then we can start working with them to design services that are going to help them maintain themselves. And I think we talk about this left shift all the time, right?
Yeah.
And we've spoken about it so long, but we just don't go and do it. We love to talk about it and not act on it because sometimes it feels too much hard work. And we have to also respect that deprived areas of this country are varied, right? But they're much more complex, you know.
Yep.
But our funding doesn't follow that in any way. And I was really worried about Pharmacy First, and I've raised it when I was on the RPS board. So I forgot to mention I was on the RPS board. I got elected with a T-shirt, but we'll come back to that. So,
right.
And I kept saying to them, you're gonna move Pharmacy First, right? You're gonna inherit all the financial funding models of general practice, and you're going to take them, because if you do a Pharmacy First consultation in a deprived area with about 12 different ethnic populations, translators, everything that you need, is so much harder. It takes so much longer. It's not as viable for you to do that there as it is in an affluent area where someone's just going to walk in, everything's fine, off they go, and they'll go and buy half the products they need because they can afford it. So why are we just walking blindly into a model that doesn't work?
Yeah, I think change is hard though, and I think number one, change is hard because there's you saying the word vested interest is wrong, but you know, any change, there's always winners and losers.
There is,
and I think what happens is if you're on the loser side, you're going to probably try and resist it a little bit, or if you can't see the plus side, you just, everyone's too busy doing their day job.
I agree.
Right? So in our particular industry, we've been so funding starved for so long. The vast majority of community pharmacy contractors now, the NHS, they've started, and that is a vast majority of our income, right? But we've started like turning your back on it is excessive, but you're looking at private income and you're concentrating on that, and it's almost like do whatever you need just to get by for the NHS side and concentrate on private income. But the people who are going to lose out the most are the ones who need it the most, right? So there's certain areas, pockets of deprivation, like you're saying. Those people and those populations are getting completely left behind. And now I can't see this changing because it's almost like it's like so hard to be able to change the system so that the funding flows the right way.
But the data's there, right? So I think even through COVID, like black people, Asian people died the most. That, you know, they were the most affected.
Really?
You know, because they lived in deprived areas.
Oh,
you know?
right, okay.
And there's, through the inquiry there was a lot of information around, you know, in those first few weeks of COVID, and ITU was full, you know, with people and stuff like that. And I think this is public knowledge. So, but you know, centrally there was a decision made not to talk about the ethnicity of the people that were in those wards, right?
No way.
Because
seriously?
Yeah, absolutely.
This is actually out there in the public domain.
It's out there, yeah.
You're not just making stuff up, are you?
No.
People are going to say it's not even true.
No, I've been privileged to go to some amazing training, and I was at the King's Fund for a few weeks of training. You know, that doesn't happen often, right? There was a guy called Stafford Scott from London who spoke to us about institutional racism within the healthcare system, within society, within London, around black people being stopped by the police. I know we're on the same trends, and I in all the clinicians that were there, I think I was the only South Asian male. There was a one black person, a black woman, and a Muslim GP from Birmingham. The vast majority of people were senior white leaders in the NHS, and there was generally silence when he was talking. And then we had the race riots not long after that. So, you know, so there's institutionally and policy and system wide, like there is an issue around how we look after people that are most in deprived. And it's not just people from ethnic minorities. There's lots of pockets that are white areas or whatever areas that are really deprived, and we have to invest more in those spaces. So,
do you think that's because the leadership within healthcare at the moment is not representative of the population as large. Is that what you think the issue is?
I definitely see that.
You definitely see that because you've been in all these different cases.
I've been in different
right?
roles. I think the hierarchies aren't always reflective of our profession. If we're just going to talk about pharmacy,
Yeah.
and I think even I know.
Why is that? Why do you reckon?
Well,
Because I've not, in my experience, I can't say I've ever come across overt racism professionally, within a profession, not at all. Yeah. So there's nothing overt. So why do you think that?
Well, it's
why do you think-
covert then. Is it covert? Is it institutional? Is it?
I don't know. I don't know. You tell
do we
me.
surround ourselves with people that we understand and know, or is it more difficult to have challenging conversations with areas that we don't understand? And I'm proud of the fact that we've got Tassé as a black woman president of the Royal College. You know. And I obviously interviewed her not so long ago, so but I'll come back to that. So that's one person, right? And I look at we don't have workforce data, right, for community pharmacy. They're trying. Well, they're trying to collect it. I don't know if it's out yet, and I haven't seen if it is. But but there was some workforce data for secondary care. It's called like PRES data that came out not so long ago, and it clearly showed like this. Especially for black females that are pharmacy technicians or pharmacists, right? That there's a certain proportion of those within the workforce, but there's very few of them at senior leadership roles.
Maybe they don't put themselves forward for it. Could that be an answer?
That's an easy way of thinking about it. I think it's the why, and you've got the attainment gaps of university where black students aren't qualifying. They're not passing their exams in the same way that other people do, and that gap's been consistently there all the time. You know, around the way that how are we taught at university? Why are these differences there, and what we're going to do about them? You know, so that's quite a broad answer.
That was deep.
It was very deep.
Yeah, it was deep. That was deep.
I think about this stuff a lot, right? But if we want change, we have to be able to understand people. We have to understand how we connect to each other. You know, and at the moment, politics and society is driven by difference. We want to look for difference and then attack it. It's not around what connects us.
Deep again.
Yeah, I'm very.
Yeah, that's a very deep again. You know what I mean? Right. So quickly, RPS. You were on the Royal Pharmaceutical Society. Yeah.
Yeah.
I'm not a member of the Royal Pharmaceutical Society.
Okay.
I stopped being a member when they
the jobs when the jobs came out the back of the PJ.
No. Not then. Pretty much. Yeah. When GPHC separated.
Yeah.
When it became, I started looking into what they were doing. I was a member for a couple of years afterwards, but then I thought, what exactly am I getting out of this?
Yeah.
And I couldn't actually work out and the problem with community pharmacy, especially contractors, we're in a very, very unique position because you've got to pay the bills and the balance sheet is pretty much primarily on your mind. Yeah. It's no matter how much you want to be, no matter how much rewarding it can be, if you upskill and you really concentrate on your profession, it's just that P&L and balance sheet just overtakes everything because you can't breathe if you don't get that right. So I think when I was looking at it, the Royal Pharmaceutical Society, I was a member for a few years afterwards, and I thought, I'm not opening no emails or letters with this. It just sits there, I'm just paying every year. This isn't for me. But you tell me, is it for me? Should it be for me? What am I missing out? Because there's loads of pharmacists who aren't members, right? Yeah. And I would say a lot of contractors aren't members as well.
I agree.
Why?
So I wasn't a member for a long time.
Okay. So you're the wrong person to ask, right?
Yeah, I think I am in a way sometimes. So I got asked to talk about my career journey at South Asian Heritage Week.
All right.
So Amandeep Dole, who's the lead for England there, she invited me down. So I went to the RPS head office for the first time in my life. I took my mum and dad with me. You know, I'm an only child, so I was like, I want you to come and see me do this. My dad didn't want to go. He was like, oh, what I'm going to speak about with all these people, intelligent people. What will I do? And I was like, you're coming. And I presented bits from my youth, from my going to India, like how I was brought up, all the cultural things that made a big difference to me, my dreads and pictures of what my mum and dad had done for me going through uni. You didn't make it in any of the photos. And my career. And at the end I said, I'm not a member. So I'm stood up here. I'm talking to you about this, but I'm not a member. And for me, I joined the day after, or maybe a week after, something like that, because I thought it's time for me to give something back to my profession. Okay. And that's why I then stood for election as well at the same time.
Okay.
your question was like, why should you be a member?
Yeah.
I feel right now we are getting eaten alive by different voices, and I don't know whether rightly or wrongly that the college should be it, but now it is a college, I feel like it needs to be in that leadership role because the government recognise it,
Yeah.
and like other royal colleges, and I feel pharmacy gets picked apart because we've got so many voices, like so many leadership voices that aren't always in harmony. When you look at other professions, when
Other professions are the same, right?
no, I don't think so. I don't think so. You look at the GP strike right now, and I know there's a lot of heat on junior doctors, right?
Yeah.
Because they keep striking.
Yeah.
But generally, when you're looking at the BMA and the other organisations, the Royal College, they stand firm. They're going to protect other parts of the profession even when they don't agree, because you can't negotiate at a table around the future for our profession when you don't represent all of it, and you can't represent all of it if you don't trust that some part of it's going to go and say something that just derails your integrity. And I think that's where the Royal College has its thing around bringing all of these parts of our profession together, being able to listen to them better, because I don't think enough listening is done. There's a lot of talking done, not enough listening, and then turns that into proper discussion around what we need to go forward and how we work together to do it. Yeah.
See, like, I'm a simple guy.
Yeah.
It all sounds very fluffy to me.
It does.
It sounds very fluffy. It sounds very management speak.
Yeah,
And this is exactly what I don't like about leadership that I've come across. Because although it's all said and all nice and well, right, and this is what everyone says that this is what we need, and no one's going to disagree with it, because how can anyone disagree with what you said?
Can't.
Yeah, so you can't disagree with it. But the reason why I don't think it's happened, I think generally across the board, the only answer is pharmacy in every sector and segment has had weak leadership. And it must be weak leadership, because if it was strong leadership, this would have been handled by now, right? The profession would have been represented better in a better light if leadership, or maybe I got it wrong. Maybe it's us at the bottom of the food chain. Maybe it's our fault. I don't know.
I never see it as a problem at the bottom of the food chain, right? Because that's the lifeblood of everything. So I think leadership's job is to listen to what's going on and try and respond to it. And I felt like that for many years. Like I didn't know who was in charge of the RPS. I didn't know who was leading the MPA. I didn't know who was in charge of the PSSC, because none of them meant anything to my life on a day-to-day basis. And I think unless we've got contractual frameworks, it's getting a bit intense, isn't it? Unless we've got contractual,
go for it.
Unless we've got contractual frameworks that touch upon hospital, community, and general practice all at the same time, that bring us to have some sort of shared outcomes and goals. 'Cause we spoke about outcomes before, right? So unless we're going to all be working towards that patient in the same way as they go through all these different parts of healthcare, what's the point?
Okay, but how do you? I think the question was, pharmacy as a profession needs strong leadership. We think a bit more unified leadership.
It does.
Whereas I always think that the leaders we have never had the. I don't think never had the wherewithal to be able to really call out or stick together when you're, let's say, calling out the government. Let's say Department of Health, right? Now, community pharmacy contractors might be having a go at Department of Health, but you might find the Royal College will say, well, that's not our department. We're not being involved in that. That's contractual. So therefore, but you say it's contractual, and this is an example, right? Community pharmacy is contractual, right? It's a business thing. And at the end of the day, they're there to represent the profession, right? Now, if this business is not funded properly, our technicians aren't paid properly, locums aren't paid properly, pharmacists aren't paid properly, then they're not happy in their profession, then they want to try and do other things. It's a massive knock-on effect. But you speak to anyone else, we can't get involved, that's a contractual dispute. It's like contractual dispute that pays everyone. So
I think that's a load of crap. So I think they've got to. I just don't see how not facilitating contracts being aligned is ever going to work, because like data's king now, right? Queen or whatever it needs to be. But if you can't show outcomes and you can't link together to deliver stuff collectively, it doesn't work. So just a few years ago, and even now, I remember the stuff appeared in the community pharmacy contract when we had healthy living pharmacies and some of the and suddenly, like, we were sending patients like by the droves for foot checks into the practice, and like the practice going, what are you sending all these people for right now? And then I think the other year there was something else which meant that community pharmacy had to suddenly start sending people in. and there was no communication between those two contractual frameworks, and all it did was create division.
Yeah.
So this feels like a great idea over here without considering the impact of that action on this part of our system. So if you can't negotiate your contract unless you understand the impact of that contract on different parts of the organisation, because you can't have shared outcomes otherwise. So you need some way you have to bring together our sectors.
Yeah.
And no, we don't have to agree all the time, but that disagreement has to happen behind closed doors.
Okay.
And we have to work out how we're going to work together and how that funding flows fairly between all of us in the right way. But if money's the driver before the outcome and we're all trying to slice our pie beforehand, it's destructive. And I think the other bit is ego, you know?
Yeah.
Ego, from what I've seen, when you talked about hierarchy earlier, kills everything. It's people's egos that drive poor behaviour and the need to behave in a certain way in certain spaces because they feel affronted. And it's ego drives so much poor behaviour. And I've got real high hopes for the board that just got elected. You know, that training that I went on King's Fund. I spent nearly 5 weeks with Claire Neverson. You know, probably the most humble people.
And Claire Neverson is
the superintendent of Boots, the chemist.
okay.
It's the most humble people I've met. We've got people like Mahendra there, Sarah Baig. We've got a young Muslim woman there, fighting her corner. There's people on there that are really humble, that understand our profession, and I think they will advocate for us rather than trying to take the limelight for stuff. There's people like you need to be supported to go and stand in a space.
Yeah.
We've got to help other people and young people that are coming through take ownership for this stuff and do it together, But that's our job now, isn't it? To bring people together.
How would you see a lot of management speaking? Because I'm a simple
not
man.
management.
This
culture.
I'm a simple man.
No.
Just tell me what
I'm preaching. I know I'm preaching.
Tell
I
me
preach
what
a lot.
tell me what you're going to do, or tell me what we should do, or tell me what I should do.
All right, okay. This is getting all technical now, right? So
Just keep it simple. Like sign up to the Royal College, will you?
Sign up to the Royal College, and also put pressure on the Royal College. Put pressure on our leadership to do what we need to do, what we need it to do for us, right? And I think, like you talked about, the ICBs and the whole environment is gone.
Yeah.
Right. Every bit of structure and studies just disappeared.
So when you say it's gone, by the way, are you talking about ICB cuts? Is
ICB,
that what you mean?
Yeah. So ICB cuts, ICB clusters.
Yeah.
So bit larger footprints have all started merging together.
Yeah.
They've lost 50% plus of their workforce.
Yeah. That's horrendous, isn't it?
It's horrendous.
So there's so many people, good people, who spent many years, basically could be their whole career, right?
Yeah.
And they've just been let go.
Discarded.
Just like that. Yeah. Why is it not? I know about it. Obviously, I'm in the industry. I know about it. But a lot of people would not know that the ICBs have been decimated like this, do they? Or do they know?
It's in the news, but I don't think they fully understand
The impact,
impact, and on the people, those individuals, highly skilled, with lots of depth. The experience you spoke to me about. There's so much experience in that space.
Yep.
And then, so they're all, they've left redundancy packages. It's agenda for change usually. Some of them it's quite healthy.
Yeah.
Redundancies for some people, not for others. And I think there's going to be a space now. There's a vacuum, and now we've got to see what happens next.
Okay.
So you can either see what happens next, or you can try and mold and influence and guide what happens next. And that's where our leadership needs to be.
Ankit, so there's new prescribers coming out from pharmacy schools en masse now. So everyone is going to be a prescriber, independent prescriber. How do you see this changing the landscape of pharmacy and the profession generally?
Yeah, it's a tricky one, this one. So I think there's a lot more schools of pharmacy as well, right? Opening up as well. So
there's loads. There's loads. Like,
you turn around and there's another school of pharmacy around the corner. So
when it comes to schools of pharmacy, I don't get it. Like, there seems to be, like before, when we went to university, there was 15, 20
I think so.
maybe?
Yeah.
I can't remember.
It's quite simple.
But now it seems like there is so many, like, I don't know. I can't understand how there'd be a requirement for that many schools of pharmacy. And how do you maintain the quality of the profession when you have that many schools of pharmacy as well, right?
I think it's a big challenge. I was thinking of quality. So I think I'm quite worried about prescribers coming into the space. I did my prescribing when I was in community pharmacy, and then I moved into a role with, I said earlier, with that experience.
Yeah.
In my PCN role, that chief pharmacist role, I interviewed hundreds of pharmacists, like hundreds of them.
Really?
And the quality of what I saw of the prescribers was very, very variable, from really poor
Yeah.
to excellent, right? And the
Okay.
very poor was scary.
Yeah. No, it's
And,
good. I agree with you.
Yeah, you know, people wanting to stop. Like, I remember one person that we did a case study with someone who had a heart attack, right? You normally get put on a torvastatin 80,
Yeah.
high dose. They just studied hypertension. They called it blood pressure. It's fine. I can deal with that. And they wanted to cut the dose of the statin. And I was like, you know, freaking out with stuff like little things like that. But actually, if you've just spent 9 months studying in a very specific area,
Yeah.
why are you at an interview? Maybe they were nervous, I don't know. But that always is stuck in my mind, those examples where I was seeing people make decisions because they felt pressure to do so, whether it was an interview situation or not,
Yeah.
without fully understanding what they didn't know.
What kind of questions were you asking? Talk about grilling them.
They got grilled.
You have an 85-year-old cardiac patient who's just been suffering from bloody hell.
Yeah, the
You know what I
interview
mean?
was about an hour, so it was
Really?
quite intense.
And you did hundreds of them.
We did 3-stage interviews, yeah, so it was quite difficult interviews, but yeah,
Wow.
But that's because I felt worried and concerned about
Yeah.
having people in the workforce that might put me in court, in the coroner's court, if something goes wrong. Because
Yeah, of course.
ultimately, when things go wrong,
Yeah.
and something happens to a patient,
Yeah.
and I'm not just trying to breed fear. We have to be responsible for the decisions that we make or don't make.
Okay.
And if you're a prescriber, whether you prescribe or don't prescribe, those both have consequences for that patient.
Yeah, of course.
And the way we're trained to prescribe is it has to be strong enough to make us feel like we know when something's wrong. And I can only think about how doctors are trained, like in this space. And I've been really privileged to go through some excellent training. I mentioned it earlier. I know everyone's not going to have had the training I've had, but look at how doctors become prescribers and the work they have to do. And I'm not saying we're doctors, but the principles of prescribing are the same. And I worry about young prescribers coming straight out of university without that life experience behind them, you know, that common sense, clinical reasoning, that bit that you build over time, suddenly having a prescription pad and then being in situations where they've got to make a decision, especially when they're isolated, especially when they're in a community pharmacy. They are the RP pharmacist and they don't have someone to call in that moment, or they don't have a network around them.
Potentially have targets.
Have targets. That's even more
Pressures,
scary.
yeah.
You know, I remember
Yeah.
the days where, you need to get 100 MURs done this week.
Yeah.
I'm like, yeah, whatever.
All right. I'm glad you didn't work for us.
Well, you know, it wouldn't have been 100, but it was
Yeah.
10 multiples, 30,
Yeah.
40 in a week.
Yeah.
No, I'm not doing that.
Yeah. I think prescribing, the workforce, you can't just have a workforce coming out being able to prescribe like that.
No.
But
They are coming out like that.
They are coming out like that, yeah.
And
But-
we've known about it for loads of years.
I know, and no one's put anything in place, including the NHS. So what happens is everyone knows that there's got to be frameworks in place, right?
Yeah.
There's got to be training. There's got to be frameworks. But you know what I find is difficult as well. I find the NHS. This is a personal feeling.
Yep.
Yeah, I'm a libertarian.
Yep.
Yeah, I'm a libertarian, and I think the NHS has so many frameworks when it comes to prescribing. Is so strict. It's almost like taking the independent out of independent prescribing. So I've actually, and I don't mean pharmacists.
Yep.
I'm talking about even doctors. Like you
Yep.
speak to a doctor and they're like, this is the framework. This is what you got to do. This is how we got to do it. And it's
Yep.
just so from ICB level, you've just got this copy and paste system
Yep.
of everything coming out. And I think, to me, I think the word patient-centered care is just rubbish. Doesn't exist. There's no such thing as patient-centered care for the
Yep.
NHS.
Yep.
It's population-centered care.
Yeah.
So what they do is work out what is best for the general population there, and everyone's doing that. And if you don't fit in, well, tough, because we can't adjust to it.
Yep.
So, as well, there's two sides to it. Number one, is there enough frameworks in place for them to be able to do it competently? Or number two, are we going to put so many frameworks in place it completely snuffs it out and there's nothing independent about their prescribing whatsoever? Yeah.
I hear you. Medicines cause harm, though. You know, they cause harm. Like whether if you take them,
You're such
or
a
you don't
systems
take them,
guy.
they cause harm.
Systems guy.
The data's there. It's all about the data, isn't it?
I know, but like,
so-
if you're an independent prescriber, I don't want to lose my independence. If I think
Yeah.
this is what's in the best interest of my patient, the whole point is, I think
Go for
it's
it.
in my I think it's in the best interest of my patient.
Oh, well, let me be clear.
Like,
I agree with you. So I think, but that's reasoning. As long as
Yeah.
you can justify your decision
Yep.
and you document it,
Yeah,
we
yeah,
haven't
yeah.
got an issue. Like, so when I came from community pharmacies to general practice, I prescribed lots of things because I did a degree in medicine.
Yeah, yeah.
Right. I understand these medicines. I've got BNF. I'm going to make a
not
decision.
strictly medicine. You mean pharmacy, of course.
Yeah, you know what I mean, though. Yeah. So I prescribe loads of different medicines.
Yeah,
sorry, yeah. So, but whereas we had other pharmacists going, I've done my prescribing in hypertension. I'm only prescribing there. I'm like, no.
Yeah.
We are experts in medicines. That's our USP.
Yeah.
We need to own that before someone else does. Yeah. And I agree with everything that you said, but we have to teach
Yeah.
people how to make a decision and how to document that clinical reasoning. Like, how have I decided with this patient it's in their interest for me to do this right now? And you have to then be able to justify it.
Do you see big cock-ups coming down the line?
I think they're already happening. Yeah, and I see more coming down the line. Yeah, because I think unless we support people and we supervise people, we create like space for them to learn from each other. It's continual education, isn't it? I look at our revalidation
But
as a
who's
prescriber.
going to pay for this? I know I keep coming back to the money is because, like I said, everything in pharmacy, in community pharmacy world,
Yeah.
has to be paid for by the
does.
contractor. So if all these things need to be done, and I don't think anyone would argue the other side of it.
No, they can't.
I don't think no one's going to argue the other
But who's
side.
going to pay for it?
Who's going to pay for it?
It's got to be. That's where you need things within contractual frameworks. You know, and it's. I mean, we don't know how PLT is going to play out and stuff, but that's a great step in the right direction. But you need to have assurance mechanisms. Like, you have to be able to say. So when the DES contract came out, and I know this isn't community pharmacy. I get that. Within our core contract,
DES contract is
the direct enhanced service contract for primary care networks.
Okay.
And that provided me with loads of opportunity to do something different. And in there it said, if you're going to have a pharmacist, they must receive monthly supervision for 4 hours, and the group of pharmacists can't be any more than 5.
Yeah.
Having a contractual enabler like that says, like, unless you do that, you can't have that money, allowed me to do something.
Yeah.
So you need contracts have to be balanced to look after our profession and the welfare of these individuals that are going to come in there to make sure they get the support that they need.
But the way commissioning works in our field, the problem is money doesn't follow it. It's just like here's the sum, whether it's whatever this envelope is.
Yeah.
By the way, here's the service. This is where you're going to get paid, and then they just put everything in that contract under the sun. But you've got to be realistic. Are people going to start cutting corners? Because is there really enough funding in there to be able to do this, achieve this properly? Or are you just putting in there to cover your back? So all the commissioners will just put everything in there. That's it. Our back's covered. It's up to them now.
Yeah.
And this is it. But if the funding isn't there,
I agree. But it's got to be built in, hasn't it? The money's not going to be magicked from anywhere, right? You can't just create it. No one else is going to pay for it. So when we're negotiating, we're building these services, we need to think about that level of supervision that's involved to make sure things are safe. But I do worry about what you just said earlier. I worry about the welfare of new prescribers coming out.
Yeah.
Just how much. There's a lot of pressure to deal with. And when in the Welsh project, I interviewed students. I interviewed people that were.
Just describe, what did you do in this Welsh? What is the Welsh project?
So the Welsh project is there was a review that I've done of general practice, pharmacy and pharmacy technicians working in general practice or with general practice.
And what is the outcome of this? What do you hope this achieves?
So there's a list of recommendations around how to make, around that. And so because it's not been published yet, I can't talk about the recommendations directly. But I went round, I spoke to surgeries, GPs, community pharmacists, students, practice managers, spoke to leadership people within the system in different parts of Wales, spoke to patients, I had to learn a bit of Welsh and do that bit of stuff as well. So, and just
go on then, let's say some Welsh.
No. Croeso means welcome. So I know. But I had to just go and listen to what people were saying and then take that information and then build it into a set of recommendations that will hopefully support a safe and healthy, workforce that's going to be able to operate in general practice.
And hopefully the Welsh government is going to take...
Yeah, so that goes through to, once it's finalised, the recommendations go through to Welsh government. They'll then be communicated there, in the Senedd that's there, and then hopefully they'll inform policy with the ones that they agree for the future.
Okay, so just to confirm, if primary care healthcare delivery in Wales turns to be totally crap,
Yeah.
that is all on you, is it?
Yeah, that's fine.
Just confirmation.
Yeah,
Okay,
yeah. So,
okay.
yeah. But and I felt that pressure though. I think because I was.
Can you imagine getting it wrong for a whole country?
It's scary. Yeah, because
a whole country.
But it's. I think when you're thinking about a system, it's that bit. It's like 1 minute I was looking after my community pharmacy. I looked after 20 stores. Then I was looking after the city of Nottingham, like with regards to my scope. Then it's been looking at a country level, and then it was like RPS border and national. So I've been exposed to a lot of different things, which has moulded maybe some of the language that I use now and the way that I'm thinking about things. It's
Management
different.
speak.
Leadership speak.
All right, leadership speak. Sorry.
Yeah.
Let me take it back. Leadership speak. Have you started your own podcast, or are you gonna start your own podcast?
You know, so I've been dreaming of doing something for ages. So, but I started it, and it's a hobby, so it all takes a bit of time. So I was at So I interviewed. I started up a company a few years last year called Remedy Roots. So that's my company.
Cool.
Yeah.
Where did that name come from?
Well, I thought I was going to start my own medicinal cannabis company and then go for it. So there was that bit.
Okay. Well, at least you got a good name there.
And beyond that, I think about roots as our heritage and remedy around how our life journeys provide part of our own healing and stuff.
So deep. You are so deep.
So, and I think that's an important thing. And so that's where the podcast is built, really, around thinking around people's life journeys and from your career journeys or from when you were born, like all the negative things that have happened, the positives, and how we respond to those, the things that we learn, the things that don't break us, that make us. And I'm a great believer in whatever happens, and this is my journey. And I can only deal with what happens now. And I feel as leaders or people in spaces, we need to share that journey to show that it's not easy to get. Sometimes life's not easy, because I think, especially, I've got two kids, they're 15, 17, and social media, the way the world is at the moment, you can look at stuff and everything just seems so straightforward, and and they don't see the ducks paddling under the water. So the podcast is all about that, to get people to talk about their heritage, their upbringing, the things that were a challenge, and things that have gone well, and how they mould them into what they are now.
Okay, is this going to be healthcare, or is it just anyone or anything?
It's going to start with pharmacy, because pharmacy is what I understand for now, and I understand. I think it's got to be about leadership in the future, or people of note that I feel I want to speak to and share their story a little bit more. So I interviewed Tassé, who's the first black president of the RPS, live at CPC. And
what's she like then?
She's a really powerful, considerate woman. I'm proud to have been associated with her, and the fact that she's leading the Royal College of Pharmacy. So I think she shared some really important things around what drives her, a part of her upbringing, and I think a lot of us have that. I heard about there's someone who's training now who came over from Syria 2 years ago. I've not even approached them yet, so and then they went to.
You can tell them right now.
Oh, right, there you go. So I just heard about them. No one told me your name, but they're doing they're in the foundation year, but they came at sixth form, went to uni, and now they're trained to be a pharmacist. And I can only imagine what their life journey has been like to get them here. And there's so many other people out there I want to speak to.
It's all about the struggle.
Yeah,
you want to hear about the struggle. You want other people to know about the struggle.
I want other people to know about the struggle, and I think at all those points in people's lives, you make connections called intersectionality, where parts of your lines cross over. And I think when I was talking earlier around, we seem to focus on difference and want to fight in that space. I think we can focus on connection and things that we've had to struggle through together. I think there's something in that brings you together really powerfully, and I think that's what I want to try and do.
Okay, so when's this podcast? Where's the timeline for this?
I tell you what, because it's on my timeline in my own time.
It's never going to happen, is it?
I think I'm going to try and get it out next week or the week. I think.
Really?
Well, whenever this comes out, I'll try and get it out soon after,
and
just get it out there, and then start getting a list of people that want to join and maybe beyond. I've been thinking about inviting some other people, or if there's people out there that are watching this going, I feel like your life journey could help others and other people that might be struggling, whether it's mental health or suicide, or like there's lots of strong.
Wow, that's some serious topics.
I've had people
like, on a podcast as well.
I know, and I have people close to me affected by stuff like this, and I think but if we don't talk about it, I've just gone through a divorce, and Like, if we don't talk about things that are happening in our lives, people just think, oh yeah, look at that, it's so easy for them. And if we don't talk about, especially in Asian subculture, there's still like shame associated with divorce, I think, in some spaces.
You reckon?
Absolutely, still, especially with the generation above.
Oh yeah,
And just, I remember Mum just like upset. She was just going, if you're happy, I'm happy, like, that type of stuff. But we need to be able to talk about this sort of stuff, don't we? I might get my mum on my podcast.
Oh, blimey. Yours is going to be so deep. The worst thing is the team know me here, right? Whenever it comes to conversations that are a bit more sensitive, I run a mile.
No.
I run a mile.
I dive in.
I don't actually know what to say. I'll be like, okay, suicide, okay. So I find it really, really difficult. So
and I love what Pharmacy Support do, like the charity, aren't they? And then they help a lot of people through some of this stuff. I think they'd asked me to come on their podcast as well because they run. I didn't know, and I thought to try and get this stuff out there. So that's what I want to talk about and get people to talk about.
Ankish, we always ask all our guests to donate to their chosen charity. So tell us, who's your chosen charity? How much are you donating, and why have you chosen them?
I think it's Pharmacy Support. So I've
good charity. I like that one.
Really good.
Yeah.
I've accessed them myself.
Oh, have you?
Yeah. When I've been struggling a bit, I've accessed them for people that I know that are close to me to get advice on how to help them or try and, when people are in dark moments, that's when we offer them intervention. And they can't access intervention in the bits when they're really struggling.
Okay.
And I think Pharmacy Support's all volunteers, and they stand up for us. And I think I've heard of too many people burn out and just get forgotten by the system a little bit. And I think they do a really important role in that space.
So how much would you like to donate to Pharmacist Support? Then,
I'm going to donate £100. So yeah.
That's really good.
Yeah.
Great charity, fully support it. That's good. This bit is the revolution that I've created. It's going to be completely anti your politics. So don't worry about that part of it. Yeah. But I've started a revolution called Make Pharmacy Great Again. Yeah. And now I'm on a mission to make sure that the profession is foremost, right at the front of everyone's minds.
Yeah.
So although I call it a movement, what it is just a bunch of merch that we walk around with, to be honest. Yeah.
It's a movement.
Yeah, it's a movement. It's a movement. So I don't even know what's in your little goodie bag of merch.
Okay.
But there's only one cap. Where's mine? Oh, he's got a cap in there.
Nice.
So you get a cap.
Oh, okay.
You get a cap.
Cool.
So you get the Make Pharmacy Great Again cap. Right.
Can I just say, I love this.
You love it?
I think we've spoken about this all day.
Making pharmacy great again.
Yeah, absolutely.
Yeah.
We've got so many people joining the profession. It's about being proud of it and putting it out there.
Well, I think, pharmacists, people don't... out of all the healthcare professions, I honestly believe the scope and the way we pivot and change to whatever is demanded of us is amazing. I don't see any other healthcare profession that can quickly adapt to a new environment very quickly, and we take it on with gusto, right?
We do. When we're too humble, we need to shout about it.
Yeah, that's exactly it. So right now I've got my quickfire questions. These are AI generated, so I have no idea what they are. So it's always a surprise to me as it is to the guest. So let's see what we've got now. Oh, these are quite cool ones, actually. Okay. If you had 100 million for healthcare, what's the first thing you'd spend it on? This is right up your street. Bloody hell.
100 million doesn't go very far, does it?
Well, come on, are you thinking about your yacht again?
If it was for pharmacy only, right?
No.
Yeah.
If you had 100 million to spend on healthcare,
now
you could spend it on whatever section you want.
Okay.
You could even turn around and say, I'll just put it all in just Manchester, just right my hometown if you want, right? So if you had 100 million for healthcare, what's the first thing you'd spend it on? It could be any part of it.
I'd spend it on community leaders. I'd spend it on helping communities get advocates that are going to help promote their health. So when we speak to communities, we've already got people around them that are able to work with us, because I think people don't understand the NHS, they don't understand public health and all of that. So if we can invest in our communities and community leaders around healthcare.
Community leaders? What is
community leader? It could be like a pastor from a church. I remember during COVID, right, there were COVID jazz being done in mosques.
I just
and
keep
churches
thinking of,
and-
you know, that Mr. Khan community
Mr.
leader.
Khan?
Mr. Khan
Ah,
community
yeah.
leader.
Oh, man.
And it's like, oh,
Oh.
God, like,
Yeah.
you want
know
to
what?
give him 100 million.
You just
yeah.
reminded me. I went back to Birmingham
Yeah.
to Aston, and my son. I used to live in Small Heath on that.
Oh, yeah,
man
yeah,
like
yeah.
Mobeen Street.
Yeah.
So my youngest, we went there, walked around the park, and then he wanted to go and see some of the stuff from Mr. Khan. And
Yeah.
I got to this roundabout, and there was this shop just that was called Convenience.
Yeah. That's a cool
Loving it.
name.
It was a great name.
Yeah,
so,
yeah.
yeah. So Mr. Khan, absolutely.
Yeah. So any communities, you'd give all our money to community leaders. I'm not sure I'd agree
Community
with that
leaders,
for healthcare.
youth leaders, but based around health.
Yeah.
Yeah, very
Okay.
much based around. So community leaders, like, you want that old gaga who's got diabetes,
Yeah.
that's willing to talk about it and share how his diet's changing. Like,
Okay.
why does? So I'm going to preach again now. I know these are short
No,
questions.
you
So
go.
my dad's got diabetes, right?
Yeah.
And he's been shocking at looking after it. Whenever he goes to an appointment, he doesn't cook. I mean, he might be able to get a slice of toast together.
Yeah.
The person that needs to be with him is my mum.
Right, okay.
Because she's the one who does all the cooking.
Yeah.
So it's like, how do we then help that community think about their food and diet and how it relates to their diabetes?
Okay.
Yeah.
Okay.
And
So
take healthcare into the community.
taking healthcare into the community.
Yeah.
I like it. There's 100 million well spent.
Yeah, I think so.
Okay. If pharmacy disappeared tomorrow,
Yeah.
what would you be doing instead?
I'll be a reporter.
Really?
Yeah. I always wanted to be a journalist. So
So why did you do pharmacy?
And
Oh
I-
yeah, you told me.
yeah, and I write poetry as well. So I've been playing poetry as well. So I might be doing something around that, but writing, some sort of writing.
Poetry. Cool.
Yeah.
That's again very deep. You're a very
It's
deep,
deep.
guy. Does it rhyme?
Not always.
Shows you my kind of poetry. I only know like loony limericks, I'm afraid. No, but
Sometimes it rhymes.
Okay, so journalist, yeah.
Yeah, journalist, some sort
What
of
kind of
journalist.
what kind of journalist? Political,
Yeah, political. Yeah, definitely.
sports.
Yeah. Well, I love sport. I love Man City. So that
You're a big Man City fan, aren't you?
Yeah, I love
You're
it.
a Man City fan before Man City was cool. Wasn't
Oh
it?
yeah, I was back at uni.
Yeah,
I think,
yeah. So,
everyone's
yeah.
just like Man City fan
Yeah,
here.
yeah,
Yeah, when
yeah.
we were in like the second division.
Yeah.
Yeah.
I bet everyone calls you a glory hunter now.
They
right?
they try to call my kids glory hunters, but I take them to the games. So yeah, I grew up in Moss Side, so I grew up next to the ground.
Yeah.
So I
right
was like, I was as close as I could be.
Okay, so last question.
Yeah.
Oh, this is an easy answer. Who's aged better since university? You or me?
Crikey me.
I don't think I can argue with that one. Spring chicken here. Yeah. Thank you so much, Ankish, for coming to the Pharmacy Planet podcast. It's been great having you.
Yeah, thank you. Thank you for listening to the Pharmacy Planet podcast. Yeah, can you please like, subscribe, share, and if you want to get in touch with Boo.
Round one, fight! The Remedy Route